We're going to be talking a little bit today about some new technology that we are bringing to Cottage Hospital and to the Cottage Health System, and that is transcatheter aortic valve replacement. So this is going to be a science-based or evidence-based lecture on transcatheter aortic valve and this emerging therapy and beyond. So before we get into the agenda, I will let you guys know I have no relevant financial disclosures to disclose regarding this topic. Our agenda today, we're going to be talking about aortic stenosis. What is aortic stenosis? We're going to talk about a change in the paradigm of treatment of aortic stenosis, which is TAVR. We'll give you the evidence as to why TAVR has gained a foothold worldwide. And then we'll talk a little bit about guidelines for patient selection, evaluation, and referral. So aortic stenosis is simply narrowing of the aortic valve. But this happens because of calcium deposits within the valve leaflets. So this is, a little schematic of a normal valve, the cartoon here, and this is a stenotic valve, and it's sort of calcified. It's like a rock pile. The patients who get this have very similar risk factors to those that get coronary artery disease. And there's a very high coincidence of coronary artery disease and aortic stenosis in the same individual. When you develop this obstruction, it is a very gradual process. The left ventricle will adapt to this obstruction very easily. But as the obstruction gets worse and worse, you get a pressure buildup inside the left ventricular chamber, and eventually the muscle gets thicker and thicker, and it develops what's called concentric hypertrophy. So I will tell a lot of patients that you've got really thick heart muscle because essentially your heart is working out all day, every day. It's like lifting weights. Remember when Arnold Schwarzenegger, the governor, was in his prime, he was huge. He was working out 8 hours a day. Now he doesn't work out as much, so he's kind of flaccid. But when you're lifting against this weight, which is your blood pressure or the pressure that the pump has to generate to open the valve, the muscle gets thicker and thicker. Over time, that muscle will eventually become dysfunctional, and you will actually have a drop in the contractility, and the heart function will become impaired. And the patients will develop congestive heart failure. So how prevalent is this? Well, it's a huge, huge problem. If you are over 65, 2% of the population has this. Over 75, it's 3%, and a staggering 4% of patients over 85. In the United States, over 100,000 patients are diagnosed annually with aortic stenosis. And it gets worse as we age, and the diagnosis is often made as someone gets older. And as we age, obviously, we're picking up more comorbidities and more risk to treatment with surgery. So the prognosis, this is a classic sort of med school topic. We always teach it's 5-3-2. And I'll tell them a lot of patients when I see them, it's 5-3-2. If you can remember anything, at 5 years, if you have angina or chest pain, 50% of people are going to die in 5 years. So if you start having a little chest pain, you have aortic stenosis, your prognosis is okay. You got 5 years to worry about this. Don't worry, we're going to get it taken care of. If you have blackouts or syncope, 50% of people will be dead in 3 years. If you have congestive heart failure, though, somebody has sort of missed it. And you only really have 2 years to live, but it's not like, we have to sound the alarms. It's just that we don't want patients to get to the point where they have congestive heart failure. And this is the classic teaching, is 5 years, 3 years, 2 years. But now what we're seeing, and now we're treating a lot of these elderly patients that have aortic stenosis, we are seeing that the mortality is much higher than we initially thought. So in recent data, we found that symptomatic patients who have moderate to severe aortic stenosis, they have a 25% mortality at 1 year and 50% at 2 years, with half of the deaths just being sudden cardiac death. That's what we're seeing in some of the registries. And based on data that I'm going to show you shortly from the partner trial, the group that's called Cohort B, their survival was only 50% at 1 year, which is pretty astounding. So this is a slide from 2004 or 2005, looking at the Mayo County database. This is, or I'm sorry, the Olmsted County database. It's Mayo Clinic. And their data set identified that the potential treatment cohort for patients with aortic stenosis was upwards of 250,000 in the United States, looking at the 2004 population. That's a lot of patients, 2004. So with all those patients, we have a real problem. The problem is that patients tend to get dramatically undertreated. And this is kind of a busy slide, but on the top here, the top bars, 54%, 43%, 60, 61, 74, 52, and 69%. These are the percentage of patients that are not getting treated with aortic stenosis. These are symptomatic patients that are not being treated because for some reason their physicians think that they have too many risk factors to treat it, or it's too morbid a procedure for them to go through. So there's this disruptive concept that was developed in the 90s, was that if we could treat a coronary artery with a balloon-mounted stent to relieve an obstruction, why couldn't we do this same concept in the aortic valve? So I've done balloon valvuloplasty since I was a fellow, and one of the first cases I ever did as a fellow was a balloon valvuloplasty, and I had no idea what I was doing. I was standing there next to my mentor. I just learned to get vascular access, and he's like, push this balloon really, really hard. And this is what happened. We cracked this guy's aortic valve, case similar to this, and the patient did fantastic for about 6 months. And balloon valvuloplasty, we can open the valves with high pressure. We can crack the calcium, but we cannot maintain this patency. There's a very high rate of restenosis is what it's called. Well, the concept was if we could mount a stent on this balloon with a lot of radial force, we could prop the valve open, and if we could put inside this stent a valvular structure, the valve that was previously there can support the whole system. This was an extremely challenging sort of combination to develop: the balloon, the delivery system, and the frame and vascular structure. So this is Alain Cribier, and this is the first man to receive a transcatheter aortic valve in 2002. They are in France, so they are drinking champagne. If it was here, I guess we'd maybe drink Pinot or Syrah, I don't know. But so I was fortunate enough as a fellow to get to meet Dr. Cribier in 2003. Shortly after he did this case, he showed up to Cedars-Sinai, where he had previously done a research fellowship, and he gathered all of the fellows and a couple of the attendings in a room about maybe a 16th of this size, and he gave us his presentation on this new technology that he was trying to develop to treat aortic stenosis. And everybody there was completely blown away by it. This happened in 2002. Obviously, it's been a very long process to get to where we are today. So we're going to talk now about the pivotal trials that have brought transcatheter aortic valve replacement to approval in the United States. And those are the PARTNER trial and the CORE valve trial. PARTNER trial was a study of patients with severe symptomatic aortic stenosis who were high risk or considered inoperable. And these patients were divided into essentially two treatment groups: treatment with transcatheter aortic valve or treatment with standard surgery. The inoperable group we will talk about, that's cohort B. These patients received essentially transcatheter valve replacement or nothing. The high-risk group was assessed by 2 cardiac surgeons and a team of cardiologists, and there had to be an agreement among the entire committee that was evaluating the patients for the trial that these patients were too high risk for surgery or were considered to have a certain risk score. And then they were randomized to standard surgery or transcatheter valve replacement. And within the transcatheter valve replacement, they could either get it through the groin or through the apex of the heart. That's called the transapical approach. These are the valves that they used back then. They only had 2 size valves, 23 and 26 millimeter valves, and these are the sheaths. So the sheath size, 22 and 24 French. That is essentially slightly smaller than this microphone. It's a very large catheter. So they were very limited in the size of arteries they could treat. It was essentially a harpoon on a stick. So this is the transapical approach. Basically make a hole in the heart, the apex, and deliver the catheter and expand it across the valve. And the transfemoral is retrograde across. When Dr. Cribier initially developed the procedure, he went through the femoral vein, did a transeptal puncture, and went retrograde through the mitral valve. So that was a much more morbid procedure originally. Here is one of my patients receiving a sapien valve. This is a XT valve, and this is being delivered via the transfemoral approach. When we deploy the valve, you rapidly pace the patient at about 160 to 170 beats per minute so that the heart sort of stands still, because it's very easy for this to slip. And if it slips, when you're deploying it, you miss, and that can be a major complication. This is a great valve. This is the sapien valve, and this is the partner valve that we're discussing here in this trial data. So to get into this study, you had to have severe aortic stenosis, defined by echo criteria, and you had to have New York Heart Association functional class 2. That means symptoms with mild to moderate exertion. And they had to be considered high surgical risk. That meant your operative mortality was more than 15%, determined by a surgeon and a cardiologist and agreed upon by an entire committee from Edwards Life Sciences, the company that was sponsoring the study. Patient characteristics were very evenly matched. There was no difference between the two groups. They were equally matched. Very high percentage of prior cerebrovascular disease, almost 30%, prior CABG and 40%, previous heart attack in almost 30% of the patients. Coronary artery disease was present in up to 75% of the patients. Almost 95% of the patients were class 3 or class 4 congestive heart failure. A fair number of patients with COPD, atrial fibrillation, almost 41% of the patients. And this frailty concept is something that's become very important as we're developing a program. Frailty was a huge issue. 15% of these patients were considered to be very frail. When we look at the echo criteria between the groups that were treated with standard surgery, that's AVR, and TAVR, there was no difference in the echo criteria. They all had the similar amount of stenosis of their valve, the pressure differences were equal, and there was an equal amount of moderate or severe mitral regurgitation, which is another serious valve issue that often requires treatment, but can be made significantly worse by just having severe aortic stenosis. If we look at the primary endpoint, and this is how we determine if a trial is successful, this primary endpoint is a composite endpoint of death, MI, stroke, and this primary endpoint was all-cause mortality. They have multiple endpoints they looked at. There's no difference between surgical valve treatment, AVR, and transcatheter valve. But it is still striking, 24 to 26% of these patients are going to be dead in 12 months. So regardless of how you treat them, at 1 year the mortality is still 25%. So this trial is considered a positive trial because it met its non-inferiority endpoint. It was designed to be non-inferior. It's equivalent to standard surgery, and that's all they needed to show. And that in itself is a very important finding. We have an option that is less morbid for our patients. If we look at all-cause mortality, including only the groin route transfemoral procedures, it's 22% versus 26%. Statistically no different, and it met the non-inferiority endpoint. Transapical, not quite as good. Numerically a little bit worse, but non-inferior. So it's certainly easier on the patients we know now to go through the groin as opposed to the apex. But this was also non-inferior. If we look at clinical outcomes at both a month and 1 year, there were some differences that are really important. So major vascular complications are certainly higher with the TAVR procedure because we are going through the groin with a 22 French vascular catheter. So you see a lot of bleeding, a fair amount of vascular injury that requires some sort of intervention. That was present in up to 11% of the patients as opposed to about 3% of patients who had a standard surgical procedure. Makes sense, 22 French versus most of these people just getting a radial art line. So there not going to be a lot of vascular issues with our standard surgical patients. Major bleeding, though, was significantly less. Surgical procedures, open sternotomy, you have a lot of bleeding. That's very common. Almost 20% bleeding with our standard surgical valve and only 10% bleeding with the TAVR procedure at 30 days. No difference in endocarditis or infections of the valves, and there was a numerically lower amount of atrial fibrillation. That was 8.6% versus 16%. And need for pacemaker was no different between the surgical valve and the transcatheter valve in this trial. If we look at stroke or TIA, there was a higher amount of stroke or TIA in the TAVR group, and it was statistically significant. It was 6% almost versus 2.5%. Major stroke was higher numerically, but not statistically significant. So the reason for the stroke rate is you're expanding a balloon across the aortic valve, and we know this from valvuloplasty. When you put a balloon across the aortic valve and you expand it, little pieces of calcium embolize, they crack, they go into the brain, which is not a good thing. So we're not, doing balloon valvuloplasty. It's not something we do as frequently in the current era. I mean, when it's necessary, we do it, but to do a standalone balloon valvuloplasty is not something that we do frequently. When we look at change in functional class at baseline, most of the patients, again, in light blue and in purple are class 3 and class 4, but out here at 30 days, 6 months, and 1 year, the vast majority of the patients are class 1 or class 2 in the yellow and light green. So there's a dramatic improvement in functional heart failure class after TAVR at 6 months, 1 year, and even 30 days. When we look at leaking in the valve, so you can get a situation, this is again, you're implanting this valve in a calcified structure, so it is not uncommon to have a leak around the valve called a perivalvular leak. Perivalvular leak is a problem. If you do not get good expansion to this valve and it leaks, it actually impacts the survival of the patient. So patients that have moderate to severe leak, they have about a 38% mortality after the transcatheter valve replacement at 1 year and up to 61% out to 3 years. So having any perivalvular regurgitation is a problem. So this is something that we look for very carefully, and we often treat, and we have plugged leaks in these types of valves when it comes up in order to help the patients. So that was the high-risk cohort. And the high-risk cohort in itself, that was a good statistically important finding that it was non-inferior to surgery. When we look at the inoperable patients, or the cohort B, again, the treatment in this cohort was the transcatheter valve or simply a pat on the back and say, go home and be comfortable. When we look at this group of patients, what we found, again, same inclusion criteria, had to have a mortality that exceeded 50%. What we found is that the number needed to treat, so this is the number we use statistically, number needed to treat was only 5 patients. That means for every 5 patients you offer this procedure, 1 is going to live that would have died otherwise. The mortality rate for patients that were treated with standard therapy was 50% at 1 year. That's that data I told you earlier. If you received the valve, it was 30%. Now, I'm not saying that this is, 30% mortality at 1 year is still quite high, and these are elderly patients, but it is a staggering difference as opposed to no treatment. And the curves continue to split as we go out to 3 years, where it's 81% mortality versus 54% mortality. And the number needed to treat gets better. It's now 3.7 all the way out to 3 years. So for the inoperable patient, this is a wonderful opportunity to change their mortality. So this led to all these publications, and these are the guys that trained me. They ran cohort B, Dr. McCarr, Dr. Fontana. I worked very closely with these guys when I was at Cedars, and Dr. Shinoda, who is one of my partners here, he actually was involved in cohort B in randomizing patients and implanting valves. All of this data led to the approval by the FDA for this valve. Unfortunately, we were the 44th country in the world, right after Algeria, to get approval for TAVR. This has been something that's been going on worldwide since about 2003, 2002. So now we're going to talk about core valve. So this is a core valve. This is a very different type of valve structure. What I've shown you before is a balloon expandable valve. This is a self-expanding stent valve. This means we unsheath it from the catheter, and unfortunately the only core valve patient that I have, Cedars, most of our patients we've referred to Cedars previously, and they use the sapien valve, balloon mounted, but now they're using the core valve because this is a very different type of structure. And this is just the best picture I can give you how the valve looks inside the patient. It's a metal cage with the valve inside it, just like the other, just like the Edwards valve, only is deployed differently. Because it is a self-expanding valve, we have different access choices. We can go through the subclavian artery, we can go through a direct aortic, small incision, and we can go transfemoral. Many different sizes. The core valve study had 4 different valve sizes. The catheter was only 18 French as opposed to 22 and 26. So this is a dramatic reduction in vascular access issues for our patients. They had the typical inclusion criteria for their study. New York Heart Association Class 2 or worse function, severe aortic stenosis, and had to be deemed at increased surgical risk. The endpoint was all-cause mortality. Non-inferiority testing and superiority testing was built into this trial. So not only were they looking for your standard non-inferiority endpoint, which is how you get your drug or your device approved in the United States. You have to show it's as good as what we already have. But they were also looking to see if it was superior. So at 1 year, the primary endpoint of all-cause mortality was actually lower for the core valve in comparison to surgical valve replacement. 3.3 versus 4.5 at 1 month, and all the way out to 1 year, 14% versus 19%. So this actually met a superiority endpoint. So now we have data for transcatheter valve replacement using the core valve that demonstrates it's superior to surgery in these high-risk patients. Their 2-year results, again, this is the pivotal trial, 2-year results show similar data, 28% versus 22%, remaining statistically significant. Which also, this is obviously great data for TAVR, but it's also kind of interesting data for a surgery. When they designed these trials, they certainly thought that the surgical endpoints were going to be worse. They thought the patients were going to do much worse with surgery than they did. And it's striking that we've been able to demonstrate this good of a result for transcatheter valve replacement, but we've also had a great improvement in surgical outcomes. A lot of these patients who would have in the past not even survived their surgery are doing much better with standard surgery even. What's interesting with this valve, there is actually a lower rate of stroke in comparison to surgery, numerically, and statistically no different. So it's equivalent to TAVR or surgical aortic valve replacement with regards to stroke rates. Major adverse cardiac events, lower with the transcatheter valve. That includes stroke, myocardial infarction, bleeding, and death. All of these endpoints together are lower. So important clinical endpoints with this particular valve that you need to know about, pacemaker implants are higher. The pacemaker implant rate is almost 20% with the core valve. It has a lot to do with that big giant metal cage. That metal cage in the inferior aspect of the valve actually presses on the conduction system and can result in the need for a pacemaker. Bleeding was lower, worse. There was less AFib, less kidney injury. Vascular complications were higher. Again, you're putting in an 18 French catheter, so you can expect there's going to be vascular injury and bleeding, but pacemaker implants were significantly higher than with the surgical group. Nonetheless, the FDA found this data compelling enough that they approved the core valve for use without even requiring an FDA panel, which is almost unheard of in the United States. Same drop in functional class. Patients did much, much better. Their New York Heart Association functional class improved dramatically with core valve treatment and stayed that way out to 2 years. Echocardiographically, it's important to demonstrate that these valves do what they're supposed to. I mean, the concern was, what if this valve isn't as good as a surgical valve? Well, it turns out it's actually better. The hemodynamics that we pick up with these newer transcatheter valves, it actually provides a larger orifice for blood flow. So that's our yellow line here, 1.94, and it stays out that way for out to 2 years. And the drop in the pressure gradient is sustained and significant from baseline to discharge, and stays no different than a surgical valve. So the hemodynamics are just as good as a surgical valve, all the way out to 3 years, or 2 years. And now we have data out to 10 years on the original SAPIEN valves, and they're performing at the exact same level that you would expect of a surgical valve, if not slightly better. So the main take-home point from the core valve data is that TAVR was favored in every subgroup analysis, and that patients did better with TAVR than they did with surgical treatment, with a higher rate of pacemaker implant. Now, there was the same issue with perivalvular leak or post-procedure AR, but they saw with this particular valve that the AR tends to get better between 30 days and 1 year, and it was maintained after 2 years. And the stent that the valve is within, the self-expanding stent, is a nitinol stent, and nitinol continues to exert outward pressure and outward force after it has been deployed. So that's why we see a change in the perivalvular leak, and the valve continues to sort of expand and push against the old valve over time. We don't see that with the SAPIEN valve, because that's basically a cobalt chromium stent, and that once it's expanded, that's as large as it's going to get. So what does it take to put one of these in? Well, it takes a village. I mean, this is a very, very big process. In order to do the initial TAVR trials, the team had to meet on a weekly basis. They had video conferencing calls with Edwards and sort of the leaders of the trial, having to discuss the patients. Well, that same concept has sort of moved forward in how a TAVR program starts up. Not only does it require an interventional cardiologist and general cardiologist, it requires a cardiothoracic surgeon. There is a huge administrative staff that is dedicated to this. You need to have a valve coordinator, which is typically a nurse practitioner or physician's assistant. That administrative staff works very closely within the cath lab, the operating room staff, critical care units, telemetry units, and multiple other physician consultants. The procedures require cardiologists and radiologists with advanced imaging skills. One of the key aspects as to why perivalvular leak has improved is because we stopped guiding the size of the valves by echo and started guiding it by CT angiography. So having a really good radiology program and doing CT angiograms of the aortic root and the aortic annulus to measure carefully the size of the annulus is why we've seen aortic regurgitation go away with this procedure. And most importantly, you need the patients and the families. This is a huge buy-in for the patients and the families. The amount of dedicated time that is necessary for the patients and the families to put into this program is enormous. And obviously the patients are sort of laying their lives out on the line for this treatment. And it also requires research staff. Every single procedure is carefully monitored, and all the data is collected and goes to a national registry, the National Valve Registry, to sort of evaluate how institutions are doing with these procedures. So the guidelines, this is a very complex technology, and since it is a very complex procedure as well, there's many interlocking steps, and there's a lot of meticulous attention to how we select these patients and how we prepare the patients in order to minimize complications. So patients who have severe symptomatic aortic stenosis of a trileaflet valve, cannot be a bicuspid valve, it's trileaflet valve, they are candidates to be considered for this. They have to have suitable vascular anatomy, and they have to have a predicted survival of at least 12 months. If they're not going to live for 12 months, this is not a procedure we would want to offer a patient. You have to have prohibitive surgical risk. These patients have to be evaluated and also patients at high surgical risk. Patients are evaluated by 2 cardiothoracic surgeons, and both cardiothoracic surgeons have to agree that the patient is not an operative candidate or is at prohibitive risk for complications. So it's a team-based approach. Because this is a very complex procedure, we have both primary cardiologists who are involved in referring the patients, interventional cardiologists performing the procedure, along with cardiovascular surgeons. There is the care team includes cardiac anesthesiology, heart failure specialists, radiology. Our nurses both in the cath lab, the units, and in the telemetry units. The cath lab team is the team that performs the actual implant procedure, and the OR team is on standby for if things go sour. And then obviously the patients and families are part of the entire process and are included carefully in every step of the process. So these are the guidelines. American Heart Association, American College of Cardiology have published guidelines basically saying that when you see the green boxes, that is a Class 1 recommendation, implying that this is what should be performed. So it is now considered a Class 1 recommendation that you need a heart team to collaborate on decisions for these patients. And if you're not suitable for surgical AVR and you have survival more than 12 months, it's Class 1 indication to consider a transcatheter aortic valve replacement. If it is it's a Class 2A, it means that the body of evidence favors doing the procedure, and it is considered acceptable if the patient is a high surgical risk. So this is an alternative for high surgical risk. Obviously, if you're inoperable and not suitable for surgical AVR, it's a go. But if you're high surgical risk, then there has to be a discussion. And the heart team is a very big part of this. So there are multiple new valves that are on the market or that are coming our way. We actually just received approval for Evolute R. This is the new valve that we will be using. This is the version of the valve that's already available in Europe and has been used for, I think, the last year. The Evolute R is the valve we'll be using. This has a slightly different or shorter skirt down here. So the actual amount of pacemaker implantation post-procedure now is on par with surgery. It's about 10%. So that's a huge change. We will be using the Medtronic valve here. We're going to be using Evolute R is our choice based on the data. And we have actually an advantage over surgery. That's why we selected to start with that valve. There are other balloon expandable valves that are now available. The SAPIEN 3 valve has been approved by the FDA. This is a change in profile for the SAPIEN valve. It's no longer 18 to 22 French. They're now getting closer to 16 French, although the Medtronic valve is now 14 French. And in a lot of centers, these are same-day kind of procedures now. It's like having a PCI. Patients come in. The way the procedure typically goes, and I'll give you guys we're kind of near the end of the lecture, so I'm going to tell you how the patients typically present for the procedure. After our heart team has evaluated them, we're going to start by finishing here by talking about our heart team. So we have a heart team here. The heart team consists of our nurse practitioner, coordinator, Jill Lowen. Jill, raise your hand so people can see you. Thank you. So if patients have severe aortic stenosis and you think they may be a candidate for this procedure, certainly you want to talk to their cardiologist. Most of the cardiologists in town have already identified quite a few number of patients that are candidates. And we're already screening and we're prepared for our first valve implants on, I believe, the 14th of September. Our team consists of myself, Dr. Shinoda. Dr. Shinoda's back here too. Thanks for coming, Mike. And Dr. Don Thomas from Cardiothoracic Surgery. So the three of us will be implanting the valves. Our cath lab team will be assisting during the procedures, and then we have a surgical team on standby for all the procedures. The patients are discussed at a valve committee meeting, and patients that are considered to be an appropriate candidate will be screened and will be further screened and receive treatment. The screening includes a CAT scan of the chest, pulmonary function testing, and just enormous amount, and I'm making this look very easy, but Jill's over here going, it's not quite that easy. There is a tremendous amount of testing and evaluation that Jill does on each of these patients to confirm that they are either frail or a appropriate candidate for this procedure. On the day of the procedure, patients are prepared to potentially have an open surgery. But our hope is to do everything through the transfemoral route. Catheters are placed in the groin, the valve is implanted. Immediately after the valve is implanted, we use per-close sutures, which is a vascular suture device, to seal up the groin. Patients go to the intensive care unit, and they're typically monitored for the need for pacemaker. Now, that was with the core valve. Now with Evolute R, we may see shorter durations of stay. We may actually see less pacemaker implants if the data holds. Well, thank you for coming out. We'll see you guys around.